tireless high-pressure pump.
Right, just constantly pushing life through miles of vessels day in and day out. But what happens when that unstoppable pump gets squeezed?
Squeezed from the outside, you mean?
Yeah, exactly. Not from a failure inside the heart, but literally crushed from the outside. So today we are pulling from a really highly concentrated stack of medical preparation notes.
These are the USMLE study materials, right?
Yep, curated by Dr. Asifullah from KMU IMS Kohat. And we are looking at two really dramatic and honestly often misunderstood cardiac conditions.
Pericardial effusion and cardiac tamponade.
That's the one. So the goal for you listening today is to unpack all this intense physiology, translate the clinical jargon, and fully grasp the life or death difference between having a little extra fluid around your heart versus, well, a fatal squeeze.
It's such a fascinating transition, going from a state of quiet baseline physiology to a sudden catastrophic mechanical failure.
And it's all about physics.
Completely. It is entirely governed by pressure and fluid dynamics. But to understand the failure, we first have to establish what the normal environment looks like.
Right, because the heart doesn't just hang freely in your chest cavity?
No, it doesn't. It's encased in this double-walled, fibrous protective sac that is called the pericardium.
And that sac isn't completely dry either, is it?
No, not at all. It holds a tiny bit of fluid, usually around 10 to 50 milliliters.
Which is basically the volume of a shot glass.
Exactly. And it makes perfect sense structurally. That little bit of fluid, which is an ultrafiltrate of plasma, it acts as a crucial lubricant.
So it stops friction.
Right. It allows the heart muscle to beat roughly 100,000 times a day without causing violent friction against the lungs and the ribs around it.
That would be incredibly painful.
It would be. And it also acts as a tether, so it anchors the heart in place. Plus, it prevents the heart from overexpanding when a bunch of blood rushes in.
Okay, so it's this highly calibrated, low-pressure system.
Right. And the trouble begins when abnormal amounts of fluid start to accumulate inside that sealed space.
And that's what a pericardial effusion is.
Exactly. Having an effusion simply means there is extra fluid present in there.
But it crosses the threshold into a true medical emergency when that fluid volume exerts too much pressure.
Right. When the external hydrostatic pressure on the heart muscle gets so high that the chambers literally can no longer physically expand to fill with blood.
Wow. And that life-threatening compression, that is cardiac tamponade.
Right, which triggers a really rapid plunge into obstructive shock.
Because the pump is structurally intact, but it's just mechanically blocked from working.
Exactly, it's trapped.
Now, there is a golden rule in Dr. Asifullah's material that I think fundamentally shifts how you have to look at this emergency.
Oh, the rate versus volume concept?
Yes. The rate of the fluid accumulation matters far more than the absolute volume.
It is the single most important thing to remember here.
We are looking at clinical scenarios where a sudden acute accumulation of just say 150 to 250 milliliters.
Which is just a small teacup of extra fluid.
Right. Just a teacup can cause fatal tamponade.
Yeah.
But then a chronic accumulation that builds up over months can reach over 1,000 or even 2,000 milliliters.
Without causing tamponade at all.
Which is wild. So volume alone doesn't dictate the severity of the squeeze. Time does.
Yeah, and the underlying physiological concept here is tissue compliance.
Break that down for us.
So the pericardial sac is made of tough, fibrous connective tissue. It's heavily interlaced with collagen.
So it's not stretchy?
Not inherently, no. If a fluid leak is sudden, like, say, from a ruptured vessel or rapid inflammation, the collagen fibers just do not have time to yield.
Right.
So a mere 150 milliliters introduced in a matter of minutes will instantly spike the internal pressure of that sac.
Turning it into an unyielding straitjacket.
Exactly.
I like to picture a tailored suit here. Like if you slowly gain 50 pounds over a couple of years, you gradually buy new clothes.
Right, your wardrobe adapts.
Yeah, the fabric of your life stretches.
Yeah.
And you can still breathe just fine.
Yeah.
But if you magically gain 10 pounds overnight while wearing that exact same tailored suit.
Oh, the fabric wouldn't have time to adapt at all.
Right, it would completely suffocate you. But on a cellular level, how is it physically possible for the human body to hide 2 massive soda bottles worth of fluid inside the chest cavity just because it happens slowly?
Well, if the leak is a slow drip over weeks or months, the living tissue of the pericardium undergoes cellular remodeling.
So it physically changes?
Yeah, the constant low-grade stretching stimulates the tissue to actually grow and add new collagen fibers.
Oh, wow.
The sac literally expands its total surface area, so it accommodates the massive new volume while keeping the internal pressure remarkably low.
And the heart just keeps pumping because the surrounding environment adapted to it.
Exactly. But in an acute setting, that compliance curve is incredibly steep. A tiny bit of fluid causes a massive spike in pressure.
Okay, so once that pressure spikes and the straitjacket tightens, the heart goes through a very specific cascade of failure, right?
It does. It starts with the fluid accumulation driving up the intrapericardial pressure.
And the material explicitly highlights that the right atrium is compressed first.
Yes. Followed closely by the right ventricle.
Which immediately impairs the filling phase.
Right, because if the right side can't fill, it decreases the preload, which is the incoming blood volume, to the left ventricle.
And without incoming blood, stroke volume drops, cardiac output plummets, and boom, the patient goes into obstructive shock.
It's a very fast, very deadly domino effect.
But I want to freeze on the very first step of that cascade.
Okay.
Wait, why does the right side of the heart lose this wrestling match against the external fluid before the left side even registers a problem?
That is a great question. We have to look at the pressure gradients that drive the human circulatory system.
Okay, so the heart is essentially two pumps operating at vastly different pressures, right?
Exactly. You have the thick, muscular left ventricle. Its job is to forcefully eject blood to the entire systemic circulation.
To the whole body.
Right, so it operates at high pressures, easily exceeding 120 millimeters of mercury during a squeeze.
Okay, but the right side.
The right side of the heart operates at incredibly low pressures. Its only job is to gently push blood right next door into the pulmonary circulation of the lungs.
So it doesn't need much force.
No, the normal pressure inside the thin-walled right atrium might only be like 2 to 8 millimeters of mercury.
Oh, wow. So it's a structural vulnerability based on its everyday job.
Precisely. If the fluid pressure inside the pericardial sac rises to just 10 or 15 millimeters of mercury,
Which is tiny.
it is, but it easily overcomes the internal pressure of the right atrium. The external fluid literally crushes the chamber inward.
Because the thin-walled, low-pressure, right-sided chambers just can't push back against the straitjacket.
They buckle first, and if the right side caves in, no blood can travel through the lungs to reach the left side.
The entire systemic pump is basically starved of fuel.
That starvation mechanism is exactly what causes the clinical reality we see in patients.
Right, which brings us to standing at the bedside. If you're a doctor, how do you spot the specific mechanical failure before the patient just completely crashes?
Well, the symptoms are driven by that plummeting cardiac output. Dyspnea, or severe shortness of breath, is overwhelmingly common.
Because they're starving for oxygen since the blood isn't circulating.
Exactly. They might experience chest discomfort, profound fatigue, and even altered mental status as the brain loses perfusion.
But there's a classic clinical hallmark taught in every medical curriculum, right?
Oh yeah, Beck's triad.
Sometimes referred to as the 3 H's.
Yes. Hypotension, high jugular venous pressure, and heart sounds that are muffled.
Let's break down the mechanics of those three because they make so much sense now. The hypotension, low blood pressure is just a direct result of the left ventricle having no blood to pump out.
Exactly. And the high jugular venous pressure, which is visible as these bulging neck veins, that is just a traffic jam.
Because the right side of the heart is crushed.
Right. It cannot accept incoming blood from the body, so that blood just backs up into the superior vena cava and the jugular veins.
You are physically seeing the backlog of the circulatory system right in the patient's neck.
It's a very clear visual sign.
And then the muffled heart sounds. I mean, that is pure physics.
It really is. The clinician is placing a stethoscope against the chest wall, but they are no longer listening to a heart beating right beneath the surface.
Right, they're trying to listen to the valves snapping shut through this thick abnormal layer of fluid.
It's literally like trying to hear a conversation underwater.
That fluid layer just disrupts the sound waves completely.
Dramatically.
Huh.
And alongside Beck's triad, there is another crucial vital sign anomaly that is heavily tested and observed.
Oh, pulsus paradox.
Yes. So normally when you take a deep breath in, the negative pressure in your chest draws slightly more blood into the right side of the heart,
Okay.
which momentarily causes a tiny, barely noticeable drop in your systolic blood pressure.
But in cardiac tamponade, that normal respiratory drop becomes dangerously exaggerated, right?
Exactly. A clinician will measure an inspiratory drop in systolic blood pressure of greater than 10 millimeters of mercury.
But wait, why does taking a breath cause such an exaggerated drop in blood pressure just because the heart is in a straitjacket?
It comes down to ventricular interdependence.
Okay, unpack that.
Under normal conditions, when you inhale and extra blood rushes into the right ventricle simply expands outward to accommodate it.
Makes sense.
But in tamponade, the right ventricle is trapped by that rigid, fluid-filled sac. It literally cannot expand outward.
So when that extra blood rushes in during inhalation,
The right ventricle has nowhere to go but inward. It pushes the interventricular septum, the wall separating the right and left sides, directly into the left ventricle.
wow, it's just stealing space from the left side.
It bows leftward, momentarily shrinking the capacity of the left ventricle.
And that sudden loss of volume in the left ventricle means far less blood is pumped out during that specific heartbeat.
Which causes that precipitous, measurable drop in the systemic blood pressure every single time the patient inhales.
That structural wrestling match is just incredible. And it also translates to some pretty wild diagnostic imagery, right?
Oh, absolutely.
Like on a standard chest x-ray, if the effusion is large and chronic, you get that classic water bottle heart.
Yeah, where the cardiac silhouette sags and widens like an old leather water pouch just resting on the diaphragm.
But the echocardiogram, the ultrasound of the heart in motion, that is the absolute gold standard for diagnosis here.
The echocardiogram is amazing because it allows you to see the pathophysiology in real time.
What are you looking for?
Well, you will observe the fluid as this dark halo around the heart. But more importantly, you will see right atrial systolic collapse and right ventricular diastolic collapse.
Diastole being the filling phase, the moment the heart muscle relaxes to draw blood in.
Exactly. If you see the wall of the right ventricle buckling inward during its relaxation phase, it means the external fluid pressure is overpowering the internal filling pressure.
That structural buckling is the visual confirmation of tamponade.
It's undeniable when you see it.
There's also a finding on the ECG, the electrical tracing of the heart, that the notes heavily emphasize.
Yeah.
Electrical alternans.
Yes.
Let me see if I have the physics of this right, because visualizing this was a total light bulb moment for me.
Go for it.
So the term just means the electrical signal on the monitor is alternating in amplitude, like a tall spike, then a short spike, then a tall spike.
Correct.
And if the heart is completely untethered, literally swimming and swinging back and forth in a massive pool of pericardial fluid, Its physical position is constantly shifting.
Yes, beat by beat.
So with one beat, the organ swings closer to the chest wall, so the electrodes pick up a strong, tall signal. But on the next beat, it swings further away into the fluid depth, so the signal looks smaller.
That's exactly it.
The electrical variation is just a shadow of the physical pendulum swing.
You've hit the exact mechanism. The physical axis of the heart is altering beat to beat as it floats in that effusion space.
It's such a striking finding.
It really is. However, it is vital for you to remember that while electrical alternans and Beck's triad are classic textbook presentations,
They aren't always there.
right, they are not always present in every patient. That is why the source material relies on mnemonics like fast heart and tamponade.
Just to maintain a wide clinical awareness.
Exactly. To ensure clinicians look for everything from tachycardic responses to early shock, rather than just anchoring on one single physical sign.
Makes total sense.
Yes.
So, since we are vividly picturing this fluid-filled sac crushing the low-pressure right heart, the logical next step is identifying, well, where is all this fluid coming from?
The etiologies are incredibly varied.
Right. On the inflammatory side, viral infections are the most common culprits.
Yeah. Viruses like Coxsackie virus have a really high affinity for pericardial tissue.
Triggering an intense immune response that causes fluid to weep into the space.
We also see bacterial and fungal infections doing this.
Malignancy is another massive category here.
Huge. Cancers of the lung, breast, as well as lymphomas and leukemias, they frequently involve the pericardium.
And in developed nations, metastatic cancer is actually the most common cause of large non-inflammatory effusions.
Yeah, and the mechanism there is twofold. A tumor can physically invade the pericardial tissue, bleeding or secreting fluid directly.
Okay.
Or the tumor can obstruct the delicate lymphatic vessels that normally drain that baseline 50 milliliters of fluid.
Oh, so if the drainage is blocked, the fluid just continuously backs up.
Exactly.
Now, in developing nations, tuberculosis completely changes the diagnostic math.
It really does. It remains a leading cause of effusions globally.
So a physician working in a region with endemic TD has to prioritize testing for that specific bacterial infection before assuming a malignancy.
Absolutely. Tuberculosis triggers a severe granulomatous inflammation in the pericardium, resulting in this highly exudative, protein-rich fluid leak.
So the context of the patient entirely dictates the hunt for the underlying cause.
It really does.
We also have obvious mechanical causes, like blunt force or penetrating chest trauma. And iatrogenic causes, meaning, an accidental complication during a medical procedure.
Like a wire perforating the tissue during a pacemaker insertion.
Right. But looking at the metabolic causes really caught my attention.
Oh, yeah.
Yeah, hypothyroidism is heavily listed. And I mean, a sluggish thyroid causing fluid to crush your heart, that seems incredibly disconnected.
I can see why you'd think that.
How does a metabolic hormone deficiency lead to a localized mechanical straitjacket?
Well, it goes back to the concept of the slow chronic leak versus the acute bleed.
Okay.
Severe hypothyroidism, often presenting as mixedema, it fundamentally alters capillary permeability.
Right.
And it impairs lymphatic drainage throughout the entire body. So the body begins to slowly leak protein-rich fluid into interstitial spaces.
Including the pericardium.
Exactly. But because this metabolic disruption happens over months or even years, the pericardial tissue has time to stretch and remodel.
This is our tailored suit scenario in action.
Exactly the mechanism we discussed earlier. A sluggish thyroid doesn't cause a violent rupture, it causes a silent systemic weep.
Wow.
These metabolic effusions, alongside those caused by uremia and severe kidney failure, they are often the ones that grow to massive sizes.
Like well over a liter.
Right, without triggering acute tamponade, simply because the compliance of the sac has kept pace with the fluid volume.
Okay, so we've mapped out the culprits, we understand the physics of the straitjacket, and we know the clinical signs.
Time for the rescue phase.
Yes. If you have a patient who is unstable, exhibiting Beck's triad, and plummeting into obstructive shock, the clock is ticking rapidly.
It's a dire emergency.
And the management guidelines outline a very specific intervention, but they also highlight a crucial do not do list that could inadvertently kill the patient faster.
Let's start with stable patients. If a patient is stable with a small asymptomatic effusion, the approach is very conservative.
You just treat the underlying cause.
Right, perhaps an antiviral or adjusting their thyroid medication, and you observe them with serial echocardiograms.
So there is no indication for routine drainage in a stable small effusion.
None. However, if the patient is unstable and in cardiac tamponade, conservative management is entirely off the table.
It is an immediate, absolute emergency requiring airway, breathing, circulation support, high flow oxygen.
And an urgent cardiology intervention.
The definitive fix, carrying a Class I recommendation, is echo-guided pericardiocentesis.
Right, because a mechanical problem requires a mechanical solution.
Explain pericardiocentesis for us.
It involves using ultrasound guidance to safely advance a needle straight through the chest wall into the pericardial sac to manually aspirate the fluid.
And removing even a small amount of fluid, sometimes just 50 milliliters.
Can dramatically drop the internal pressure of the sac and instantly restore the heart's ability to fill.
That's amazing.
For recurrent effusions or, thick, complex fluid that just won't drain through a needle, a surgical pericardial window might be required.
Where a surgeon removes a small piece of the sac to allow continuous drainage into the surrounding chest cavity. Now, preparing a sterile field and getting the ultrasound team ready, that takes precious minutes.
It does.
To keep the patient's pump primed until the needle is in place, the protocol suggests giving a small IV fluid bolus for temporary stabilization.
Yes.
But under the big, bold avoid list, It strictly mandates.
Yes.
Do not give diuretics. Do not give vasodilators, and avoid positive pressure, ventilation-like intubating the patient before drainage, if at all possible.
It's a very strict list.
I have to vigorously challenge the logic here, though.
Okay, let's hear it.
The patient's heart is literally drowning in an ocean of fluid. Their jugular veins are bulging from the backlog. The immediate instinct should be to dry them out with diuretics, not pump them full of even more 5V fluid.
Yeah.
Why are we adding fluid to a fluid problem?
It sounds crazy, right? But the counterintuitive nature of this treatment is where a deep understanding of hemodynamics is totally essential.
Okay, walk me through it.
You must distinguish between compartments. The fluid causing the problem is not inside the patient's bloodstream. It is trapped in the sealed anatomical compartment outside the heart. The patient's actual circulatory volume might be perfectly normal, or they might even be depleted.
So the fluid is just in the wrong place.
Exactly. And remember that the low-pressure right ventricle is being crushed inward by that external hydrostatic force.
Right, the straitjacket.
The only physical mechanism keeping that chamber propped open is the internal pressure of the blood returning from the body, the preload. That internal venous blood acts as a structural scaffold fighting the external squeeze.
So if you administer a diuretic,
you force the kidneys to excrete fluid, which decreases the total volume of blood inside the veins.
you remove the scaffolds.
Yes. If you drop the internal venous pressure while the external pericardial pressure remains high, the right heart will instantly buckle and collapse completely.
And systemic circulation stops, and the patient dies.
Exactly. Vasodilators do the exact same thing by relaxing the veins and pulling blood away from the heart, dropping that critical filling pressure.
Wow. So by giving a small, fast IV fluid bolus, you are intentionally packing the venous system.
Artificially cranking up the internal pressure to force the right heart to stay open against the straitjacket, just long enough to get the needle in.
That is brilliant. And that makes the avoidance of positive pressure ventilation make perfect sense too.
Right.
If you intubate a patient and force pressurized air into their lungs, those expanding lungs increase the overall pressure inside the chest cavity.
Yep.
You are basically adding a third layer of crushing force, pushing down onto the pericardium, which pushes onto the right heart, completely collapsing whatever fragile hemodynamics were left.
It is a delicate balance of physics. You must maintain the internal pressure to fight the external compression at all costs.
So for those of you studying this pathology, or really anyone fascinated by the mechanical thresholds of the human body, the through line here is all about pressure gradients.
Absolutely.
Remember that speed kills. The rapid accumulation of a teacup of fluid is vastly more dangerous than a slow chronic leader.
And recognize that the domino effect always begins by collapsing the low pressure right side of the heart.
Setting off the alarms of Beck's triad, pulses, paradoxes, and electrical alternates.
And above all, if the heart is being crushed from the outside, it desperately relies on internal fluid pressure to stay alive.
Do not remove that internal scaffold with diuretics.
Exactly. Exploring this level of mechanical failure really forces us to consider the broader evolutionary trade-offs inherent in our biology.
What do you mean?
Well, over millennia, human anatomy evolved this tough, fibrous pericardial sac. It's a brilliant evolutionary shield designed to protect our most vital organ from friction,
Right.
to ward off creeping infections from the lungs, and to prevent dangerous overexpansion during heavy exertion. It is meant to save the heart.
Right.
Yet, under the specific circumstances of rapid fluid accumulation, this exact protective shield becomes an unyielding prison.
Wow.
The very anatomical feature designed to protect the system becomes the primary instrument that crushes it.
That's haunting.
It invites a fascinating question for you to mull over. What other deeply ingrained protective systems, whether in our biology, our defensive technologies, or even the structures of our societies, run the risk of becoming the primary threat to our survival when the surrounding environment suddenly changes?
Now that is a profound paradox to leave you with as we wrap up today's exploration of the ultimate internal engine. Stay curious, keep analyzing the mechanism